Hi, in this video lecture I will introduce you to the types of spaces or organizational units of the body, as well as structure and the common features of the serous cavities, which contain majority of bodily organs. Spaces within the body can be divided by the various criteria. According to the development, body cavities are divided into the ventral and dorsal cavities. If you recall that dorsal ectodermal part of the embryo forms the neural groove, which later closes and forms the neural tube, the later CNS, which lead us to the name of cavities surrounding the CNS, the cranial cavity and the spinal canal, the dorsal cavities. The frontal portion of the embryo is first communicating with the yolk sac, and later the transformation of this space creates the digestive and respiratory organs, and around them future ventral cavities. Ventral cavities are further topographically divided into the thoracic, abdominal and pelvic cavities. All three of these ventral cavities are at least in part surrounded by the serous membrane, and thus they are called the serous cavities or serous spaces. And these spaces are the pleural, the pericardial around the heart, and the peritoneal space. There are some additional spaces which are not lined with the serous membrane, and they also contain organs which are inserted into the connective tissue. So these spaces are called the connective tissue invested spaces and or fibrous tissue invested spaces. And these are the mediastinum in the thoracic cavity in the central part, the retroperitoneum, which is located behind the abdominal cavity, and the subperitoneum, which is located in the lower part of the pelvis. In front of the peritoneal cavity and above the symphysis here is the preperitoneal space, which actually represents the reserve space for the expansion of the filled urinary bladder. Observed microscopically, membranes are generally sheets of connective tissue covered with epithelium, unlike, for example, the fascia, which has no epithelial cover. Depending on the type of the epithelium covering the membrane, they are divided into the serous and mucous membranes. And the serous membranes are transparent, and they are covered by a cuboid epithelium shown here, which secretes thin and translucent so-called serous fluid. The mucous membranes not shown here are opaque in appearance, and they are covered by mucus secreting epithelium, and an additional special type of membrane is the skin, whose surface epithelium is keratinized. The serous membrane therefore consists of two layers: the epithelial layer, or lamina epithelialis, or the mesothelium, which is formed by a single row of cuboid cells overlaying a loose connective tissue underneath it, which is rich with nerves, blood vessels and lymphatic vessels, and this subserosal tissue is called the lamina propria or subserosa. Both layers are present in the microscopic sheets of a serous membrane or the anatomical layers. In the example of this abdominal serous membrane, the peritoneum, the visceral layer, which surrounds the organs, represents a thin layer on the surface of the intestinal loops, whereas the parietal layer represents the shiny, smooth surface of the interior abdominal wall. The smooth structure of the serous fluid secreted by the mesothelium facilitates the sliding of the organs situated in the serous cavities. The visceral layer of the serous membrane is also called the serosa of the organ. In the connective tissue spaces, on the other hand, organs are surrounded only by a loose connective tissue, which has no epithelium on the surface, and such envelope is called the adventitia. This figure shows the three major serous spaces of the body, all possessing a parietal and visceral layer, whose names change depending on the space to which they belong. And thus we can recognize a parietal and visceral pleura, a serous membrane of the thoracic cavity and lungs, a parietal and visceral layer of the serous pericardium investing the heart, and the parietal and visceral peritoneum, which represent the lining of the abdominal cavity and organs. Their role changes depending on the space. In addition to previously mentioned role in peritoneal organ gliding and reducing friction, the serous lining of the thoracic cavity has important role in expansion of the lungs during respiration due to the negative pressure between its layers. The relation between the parietal and visceral layer of the serous membrane is best illustrated by the hand pressed into the inside of an inflated balloon. The outer surface of the balloon represents the parietal layer, which is connected to the wall of the corresponding cavity. Paries in Latin means the wall, which reflects its position on the wall of the cavity, and the part of the balloon that clings onto the fist is the visceral sheet of the serous membrane, shown here the organ, and similar to the surface of the balloon, the sheets of the membranes are also continuous with each other and pass from one into another. In the area of transition to the organs, they adhere to each other and thus form a duplicature, which is called the meso. And this meso is named depending on the organ it wraps. For example, mesogastrium, mesentery, mesopneumonium. These mesos are important because they bring blood vessels and nerves to the organ. In addition to the described mesos, folding of serous membrane results in the formation of several types of serous structures. Duplicatures include the described mesos, as well as the serous ligaments, which are found mainly in the peritoneal cavity and represent diffuse sheets stretching between organs and the wall of the cavity or two connected organs. And examples of such duplicatures are the pulmonal, the gastrocolic ligament, falciform ligament, and many others. Specific duplicatures which are related to the curvatures of the stomach are the ommenta. There are two of them, lesser and greater omentum. And in addition to duplicatures, there are also folds or elevations appearing in places where the serous membrane covers the blood vessels or the nerves or connective tissue bundles, which are most often obliterated embryonic structures, such as, for instance, in the umbilical folds. Folding of the serous membrane within the corresponding cavity also leads to the formation of depressions or sacs of various depths and size. Examples of such depressions are many. For instance, the pericardial sinuses or numerous sacs of the abdominal cavity, which are named differently, like recesses, fossa, bursa, and the like. As I mentioned earlier, duplicatures of the serous membrane contain blood vessels, nerves, and other structures, such as main bronchi on this example. In this regard, several terms needs to be defined. The place where the structures enter the organ is called the hilum. The bundle of structures surrounded by a serous membrane represents the root or radix of the organ, and the serous duplicature itself it's called the meso, in this case the mesopneumonium. The body cavities are arterially supplied by the branches of the descending part of the aorta, the thoracic and the abdominal aorta, which by reaching the level of fourth lumbar segment divides into its terminal branches, the common iliac arteries. Branches for the wall of the cavity or parietal branches are mostly paired, and they also supply the parietal layer of the corresponding serous membrane. These are in the thoracic aorta the intercostal arteries, at the diaphragm the lower or the inferior phrenic arteries, and in the abdominal aorta the lumbar arteries shown here, and in pelvis the lateral sacral arteries which originate from the iliac arteries, and of course the only unpaired parietal branch of the abdominal aorta, which is called the median sacral artery. Anterior thoracic wall, pericardium, and part of the anterior abdominal wall as well is supplied by the internal thoracic artery, which is a branch of the subclavian artery, and the lower part of the abdominal cavity is mostly supplied by the branches of the external and internal iliac arteries and the femoral artery. Visceral branches supply organs, and they can be paired or unpaired depending on the organs they supply. So thoracic aorta gives the bronchial and esophageal branches, and the abdominal aorta gives three large unpaired branches for the all digestive system organs, which are the celiac tract, the superior mesenteric, and the inferior mesenteric artery. The paired visceral branches of the abdominal aorta, like these renal arteries and testicular or ovaric arteries, supply the paired organs of the urinary system and gonads, thus, and the pelvic organs are supplied mainly through the visceral branches of the internal iliac artery. Venous blood of the thoracic wall is drained by the azygos and hemiazygos veins, receiving the posterior intercostal veins, whether the veins of the anterior wall flow into the internal thoracic vein and further into the superior vena cava from both systems. The other parietal veins of the thoracic and abdominal wall correspond to arteries, and blood from the paired organ of the urinary and genital system is drained directly into the inferior vena cava, whereas blood from the digestive organs is collected by the portal vein and first passes through the liver, and after that enters the inferior vena cava through the hepatic veins. It is important to emphasize that arteries and veins from the walls of the trunk form the surface network with multiple anastomotic connections, representing a potential collateral circulation that allowed to bypass the potentially narrowed part of the aorta or the superior or inferior vena cava. In addition to the walls of the cavities, arteries and veins also anastomose at the organ level. For example, the branches of the celiac trunk anastomose with each other, forming arches around the stomach. Superior and inferior mesenteric artery are interconnected by an arterial arch along the large intestine, and the rectal, arterial and venous network allow communications between the branches of the descending aorta and the internal iliac artery, and as well as between the portal vein and the inferior vena cava. And the last connection is especially important in cirrhosis of the liver, the condition where the blood cannot pass through the damaged liver and is reaching the inferior vena cava by special anastomotic networks. The wall of the cavities and thus the parietal sheets of the serous membranes are supplied by the corresponding branches of the spinal nerves. There are intercostal nerves in the thoracic and upper abdominal cavity, as well as the branches of the lumbar plexus. Also, phrenic nerve, which is shown here next to the heart, is the branch of the cervical plexus, which is involved in the sensory innervation of the pericardium, pleura, and upper part of the parietal peritoneum. These are the general somatic afferent fibers, and therefore the parietal layers are sensitive to pain. The visceral layer of the serous membranes have no somatic nerves and are therefore insensitive to painful stimuli. The sensation from the visceral layers, however, is transmitted by the general visceral afferent fibers that accompany the nerves of the autonomic nervous system and run in various networks of plexuses, such as the cardiac, pulmonary, celiac, mesenteric, and hypogastric plexus. And depending on the plexus, the fibers access the spinal ganglion or switch in the posterior horn of the segment which receives the corresponding autonomic fibers. And in the continuation of the lecture, I will describe in more detail the principles of innervation of body cavities, especially organs. I will first remind you on the division of the peripheral nervous system into the somatic part, involved in voluntary motor activity and conscious recognition of bodily sensation, with which you have already become acquainted while studying the locomotor system. The structure of the autonomic part of the nervous system is important to understand the innervation of organs, because the efferent fibers of this system affect activity of internal organs, for instance, the contraction of the smooth muscles of the blood vessels and the secretion of glands, while their afferent fibers conduct sensation from the walls of organs and glands, and according to their effects on the target organs, the autonomic nervous system is divided into the sympathetic and parasympathetic portion. In addition to the somatic fibers, the autonomous fibers are also a component of the spinal nerve. So, efferent autonomous fibers or general visceral efferent fibers are axons of neurons whose bodies are located in the lateral horns of the gray matter of the spinal cord, which are not present at all segmental levels, but only in the thoracic and the sacral segments. So the thoracic segments provide the sympathetic efferent fibers for the whole body, and sacral segments of the spinal cord provide the parasympathetic fibers for the innervation of the pelvic and lower abdominal organs. Parasympathetic fibers, in addition to this portion, for the rest of the abdominal and all thoracic organs, originate from the 10th cranial nerve, the vagus nerve, and could be also found in some other cranial nerves. So afferent autonomic fibers, or the general visceral afferent fibers, do not recognize the general sensation, but represent free nerve endings sensitive to stretching of the organ or blood vessel wall. And these are the thin, unmyelinated axons, whose bodies are also located in the spinal ganglion and play an important role in the control of organ activity, blood vessel diameter, and cardiorespiratory function. Unlike general somatic efferent fibers, which create a synapse or switch only once at the level of neuromuscular junction, neurons of the autonomic nervous system, on their way to target organs, need another synapse or switching. This occurs in the ganglia of the autonomic nervous system, and we can therefore distinguish between the preganglionic and postganglionic neurons of the autonomic nervous system. All preganglionic neurons secrete acetylcholine at the synapses, which is also the main executive parasympathetic neurotransmitter. The transmitters of postganglionic sympathetic neurons are epinephrine and norepinephrine. So the postganglionic neuron actually determines the different effects of the parasympathetic and sympathetic fibers on the target organs. In addition to the above mentioned, it is important to mention also that the axons of the preganglionic neurons are myelinated, while in the postganglionic neurons, axons are thin and devoid of myelin sheath. This figure shows the distribution and action of the sympathetic and the parasympathetic nervous system. The sympathetic nervous system, shown in green, stimulates the cardiac activity, raises blood pressure, acting primarily on the contraction of smooth muscles in the walls of blood vessels. And the only glands whose activity is stimulated by the sympathetic system are the sweat glands. On the other hand, the predominant effects of the parasympathetic nervous system, which is shown in violet, are to stimulate the contraction of the smooth muscles and motility of the organs, as well as the secretion of digestive and salivary glands. And by acting on the conductive system of the heart, the parasympathetic nerves slow down the heart rate. Preganglionic sympathetic neurons are located in the lateral horns of the thoracic spinal cord, as I mentioned before. So these neurons switch in the ganglia situated on both sides of the vertebral bodies and are thus called the paravertebral ganglia. The paravertebral ganglia are interconnected by the nerve fibers, and together with them they form a sympathetic trunk. Some neurons switch in the ganglia of the sympathetic trunk, whereas others continue as the preganglionic myelinated fibers, bypassing the paravertebral ganglia as splanchnic nerves. These fibers switch in the ganglia which are located mostly around the origins of the large aortal branches, the celiac trunk, the superior and inferior mesenteric artery, referred to as the prevertebral ganglia because of their position in front of the vertebral column. Thin, unmyelinated postganglionic fibers join the blood vessels, thus forming the perivascular plexuses, and in this manner reach the target organs. Preganglionic parasympathetic neurons are located in the nucleus of the vagus nerve and in the lateral horns of the segment S2 to S4 of the spinal cord, the latter leaving the spinal cord as the pelvic splanchnic nerves. And parasympathetic neurons mostly switch near the target organs, and therefore the postganglionic axons of the parasympathetic system are short. It is also important to mention that additional parasympathetic supply for the head and neck comes from the nuclei of other higher cranial nerves and is switched in some special ganglia, while the sympathetic supply for the whole body comes from the thoracic segments of the spinal cord. The autonomic nervous system plays an important role in the control of many internal body functions, taking place through different reflex arches. An afferent arm of these arches consists of receptors in the wall of, for example, blood vessels or organs, which are reactive to stretching. Afferent fibers run with the corresponding autonomic or cranial nerves, and these stimuli result in the activation of the relevant efferent part of the autonomic system. Some of these arches continuously monitor the activity of autonomic nervous system. For example, an increase in blood pressure will cause the stretching of the wall of the aortic arch or the common carotid artery, which will stimulate the baroreceptors, and via visceroafferent fibers in the 9th and 10th cranial nerves, their impulses will reach the vasomotor center in the medulla oblongata, to stimulate the parasympathetic and inhibit the sympathetic activity and thus decrease the blood pressure. Some autonomic reflexes are typical executive reflexes, such as, for instance, bladder emptying. Stretch receptors in the bladder are triggered by its feeling and transmit impulses via the afferent nerves in the composition of the so-called pelvic splanchnic nerves towards the S2 to S4 segments, where they stimulate efferent parasympathetic neurons, which via the same nerves induce bladder emptying. All autonomic reflexes are complex and multisynaptic, and they are very often also under control of some higher centers in the central nervous system. Although the internal organs do not contain general somatic afferent fibers, intensive stretching or excessive damage to their walls result in the pain sensation, which is not localized in the organ itself, but in a certain superficial area of the body, which doesn't necessarily have to correspond to the actual location of the affected organ. Such areas are called the head zones, and this type of pain is called the referred pain. The mechanism underlying this type of pain has not yet been fully elucidated, and the phenomenon is quite complex, but it can be at least in part explained by the convergence of the visceroafferent and somatic afferent fibers to the same spinal segments. For example, the visceroafferent fibers of the heart are part of the cardiac plexus and reach the lower cervical and thoracic segments via the cervical part of the sympathetic trunk, which partially correspond to the distribution of lower cervical and upper thoracic nerves, and explains the distribution of pain in myocardial infarction in the upper chest, shoulder and arm, and similar regions are also described for some other organs which have more or less typical distribution of pain.